I don't know if any one of you have seen this movie, but I thought this clip is going to be very important in helping you to understand how the IgM reacts against the epitopes that it sees or against the antigens, and how you can distinguish it from the function of the IgG. This one pertains to the movie The 51st Dates, and I somehow do a little paraphrasing and use the concept, and I'm saying the 51st antigenic dates of the naive B cells. The plot of the 51st Dates movie is that Henry meets Lucy, who has short-term memory loss, and falls in love. The problem is that when she wakes up every morning, she can't remember Henry. So every day thereafter, for the rest of his life, Henry tries to get Lucy to fall in love with him again. And that's the very same story and kind of concept which is, in a sense, applicable to IgM antibodies. Naive B cells always react to the same antigen as if it's the first time that they see the antigen. That is, IgM production by naive B cells occurs in all repeat exposures to the very, very same epitope and very same antigen. Naive B cells do one good thing, and they do it well. That is, they make IgM that stays in the blood for about 3 to 4 weeks. As you can see in this diagram, the red lines, the red curves, pertain to the B cells' production of the IgM. Starts maybe on about day 5 to 10, hikes up thereafter, peaks at about 20 days after exposure, and drops down at about 30 days after the exposure. However, look at the blue line that pertains to the formation of IgG isotype against the very same antigen. It starts a little later than IgM, maybe on day 15 or 16, and then gradually rises and maybe peaks at about 30 days and stays at the plateau level, maybe may drop a little, but it stays high at about maybe 40 days after the first exposure. After the first exposure to antigen, many B cells will become memory B cells and plasma cells with excellent short and long-term memory of the very same antigen. These plasma cells are proficient in producing high titers of IgG and IgA antibodies against the very same antigen or epitope soon after their subsequent exposures. They produce IgG in the tissues and IgA on the mucosal surfaces. Why is IgM the best immunoglobulin for the first encounter or repeat encounters of the very same antigen? The reason is that IgM molecules are master neutralizers because they make pentamers with 10 binding sites for the very same antigen. So they identify the antigen first in the blood, neutralize it in the blood, will now allow it to enter into the cells of your body from the blood or in the tissues for the same reason. To summarize, as you see in the diagram, each subsequent exposure to the same epitopes, the IgG titer progressively rises. What is the most important role of booster vaccinations? Hyperaffinity formation. One of the outstanding features of memory B cells is production of antibodies with a much higher affinity for antigenic epitopes as a result of the so-called somatic hypernucleation. mutation, which we use at times as a synonym for hyperaffinity formation. Subsequent vaccination greatly enhances the affinity of immunoglobulins as a result of constant point mutations in their antigen binding sites. This is followed by selection of B cell clones with progressively higher affinity for the very same antigen. Note that a booster vaccination with T cell dependent antigens involves activation of memory B cells and requires less antigen and fewer CD4 positive T lymphocytes than the activation of the original naive B cells. I'm going to be covering the concept of vaccinations and T cell dependent vaccinations a little down the road for you in details, but these are here to just orient you a little to the concepts. Another important issue that I like to pick up at this point, and hereafter we're going to be using just the name of the test, but I thought it's very important for you to know a little about the details of these technologies. We're going to refer to this diagram that I'm showing on the right side of your slide. Complement fixation test identifies presence of a specific antigen or a specific antibody in the serum. Currently, it is replaced by other methods of pathogen identification, such as PCR and ELISA. Of course, PCR stands for polymerase chain reaction, and ELISA stands for enzyme-linked immunosorbent assay. Serum of a patient suspected of a particular disease who indeed has that particular disease is placed in a beaker. This is a step number 1, or a step that I have labeled number 1 in a diagram for you. I want you to note that the right panels illustrate the steps assuming that he has no exposure to the antigen, means that he has no antibodies in his or her serum against the pathogen. The left side panel or the left side beakers show the patients who are sick and who are exposed to the pathogen, and they have antibodies against that particular pathogen. And in this diagram, I'm showing those antibodies in red, and those green pictures that you see, or oval pictures that you see, those are the complements. The next step, or to be exact, the first step, is to standardize the amounts of the complements in patient's serum by heating the sample at 56 degrees of Fahrenheit to destroy the complements, because complements are heat labile. And that's why I have the thermometer in this diagram. The rationale for this is that individuals have variable complement levels in their blood, and removal of the complements will allow us to add standardized levels of complements and antigen against the tested antibody to the tested samples or the tested serum of the patients. This is the event number 3. And in here, you see that we have removed essentially the antibodies. And of course, patients who are healthy in stage number 2, you see that after heating, we destroy the complements. However, then we come and on stage 3, we add essentially the complements and antigens into these beakers. The exposed or the sick individual complement is now fixed by a reaction with antigen antibody. In the non-exposed serum, there are no antibodies to complex with the antigens, and as a result, the complement will not be fixed. This is a stage number 4, or a step number 4. To determine if the complements are fixed, now we add sheep red blood cells and the antibodies against them into the samples. This is step number 5. In the exposed or sick individuals, presence of antibodies against the pathogen means that the complements are already attached to the antibody-antigen complexes, as you see in the diagram. As a result, the sheep red blood cells will not lyse. However, in the exposed individuals, the sheep antibodies will clump together and precipitate the red blood cells. This is the step labeled number 6. In the non-exposed serum, the complements are freely present and they can react with the antibodies and red blood cell surface antigens. Complement fixation in the non-exposed serum leads to formation of membrane attack complex and as a result perforations of the red blood cell membrane and as a result hemolysis. This is what you see in the step number 7. As you can see, in the healthy individuals, the sample gets red because of hemolysis, but this doesn't happen in sick individuals because the red blood cells are precipitated at the bottom of the beaker. So what is the term that best describes the coating of a bacterium with antibody to make it more susceptible to phagocytosis by macrophages or neutrophils? This is opsonization. What is the term that best describes the coating of a bacterium with C3b component of complement to allow it to bind to C3b receptors of the macrophages? Again, this is opsonization. And of course, I've already shared this mnemonic with you that C3b in particular and C4b as well, they are known as famous opsonines. And opsonin or opson, I said, means cuisine, and I've used the mnemonic of bonbon for B to know that a bonbon is a candy coated with chocolate, and in mnemonic you see 3 candy canes, and anyhow, this mnemonic reminds you of the fact that these candy canes attract the neutrophils to where the bug is located. How is the complement fixation CF test quantified? By serial dilution of the patient's serum and determining the highest dilution level that produces a positive CF test. What is the underlying mechanism of the complement fixation test? Antigen-antibody complexes have the ability to fix and consume complements if and only if complements are present, whereas free antigens or free antibodies cannot fix complements. That's the underlying required mechanism for complement fixation test. It's about the best time for me to orient you also about another concept which is relevant, and that's heme agglutination. Heme agglutination is a special case of agglutination that specifically involves agglutination of red blood cells. Viral heme agglutination, HA, and heme agglutination inhibition assays, HAIs, are 2 tests that identify presence of specific agglutinating antibodies in the blood of patients suspected of having certain diseases. Lab serology of influenza virus is one of the common indications for the HA and HAI tests. This is about a good time also for me to talk about hemagglutinin and neuraminidase of influenza virus. Influenza virus has 2 major virulence factors, hemagglutinin, HA, and neuraminidase, NA. Hemagglutinin is a glycoprotein on the surface of the virus. It binds the virus to sialic acid molecules on the cells of, in particular, respiratory tract and on the erythrocytes. The binding of HA is the first required step in the pathogenesis of influenza. HA and HAI tests are used to identify presence of serum antibodies against influenza virus. The foundation of these two tests is based on the fact that if there are antibodies to influenza virus, that you see it in a patient who has contracted influenza. In the tested samples, they prevent attachment of the virus to the red blood cells. In other words, they will inhibit heme agglutination. Note that when hemagglutinins of influenza virus bind to sialic acid, they form a mesh of interconnected red blood cells and viral particles that maintain the red blood cells in a suspended distribution, and as a result, this is seen as a diffuse red colored solution in the lab. The formation of the lattice depends on the concentration of the virus and the number of the red blood cells in the sample, such that when the relative virus concentration is too low, the red blood cells cannot make a mesh-like lattice and they settle down at the bottom of the well. This diagram summarizes the events in hemagglutination and heme agglutination inhibition. On top, I'm showing the heme agglutination inhibition. At the bottom, I'm showing the foundation of heme agglutination test. On top, as you see, we have the red blood cells, we have the virus with heme agglutinins on them in the blood of the patient. We also have these antiviral antibodies. I'm showing them in purple color. Now these antibodies, the Fab regions of the antibodies attached to the antigen of the virus, the heme agglutinin antigen, so they coat the virus, will not allow the virus to attach. They neutralize, if you wish, and will not allow the virus or viral particles, if you wish, to attach to the red blood cells. However, at the bottom, you're going to see influenza virus, and also you're going to see the red blood cells, but this time we do not have the antiviral antibodies, and as a result, the viruses are able to attach essentially to the red blood cells, and as a result, they cause agglutination of the red blood cells. So what is the meaning of antibody titer in heme agglutinin and heme agglutination inhibition test? This means the lowest concentration of the antibody against an antigen as it is determined by serial dilution process. Name major pathogens with heme agglutinating effects. So, as you can tell, there are more viruses than the influenza virus with heme agglutinating effects. One is Newcastle disease virus. This virus is more important in the poultry and first identified in England, so the name Newcastle refers to that. It's an RNA paramyxovirus. From a standpoint of human medicine, it is of interest to us because it replicates extremely fast in human cancer cells and can kill the cancer cells as a result of it. As such, this is used as a vaccine against cancers. Newcastle disease virus may only cause mild influenza-like symptoms and conjunctivitis, more commonly in poultry handlers. The other virus of interest is adenovirus, and not all types, only some of the subtypes of adenovirus can have heme agglutinating effects. Another one is Mycoplasma bacteria. What is the name of a hematological test that utilizes agglutination principles, but this time tests for non agglutinating antibodies that are directed against the red blood cells. So this is a good time for me to cover, as you can tell, the relevant concepts so that you can learn about the foundation of these lab tests. This is going to be the Coombs test or Coombs reaction. Of course, as you can tell, we have two types of Coombs tests that they are analogous to heme agglutination tests that we covered earlier. The two subtypes of Coombs tests are direct and indirect. What is, in the final analysis, the Coombs reagent? Coombs reagent is also known as anti-human globulin, AHG, Coombs antisera and antiglobulin reagent. The most important function of anti-human globulin reagent is to detect presence of IgG or complement C3b that causes hemolysis of the red blood cells. The Coombs antiglobulin antibodies are developed in the lab animals such as rabbits, and they are injected with IgG antibodies. Does agglutination occur in the blood of newborns with hemolytic anemia without another antibody present? The answer is no. In order for agglutination to take place, another antibody, your famous Coombs reagent, must be present. This reagent specifically reacts against the Fc portion of the IgG antibodies that cause hemolytic anemia, and they must be added in the lab to the red blood cells. This diagram represents it very well for you. And the Coombs reagent in this diagram are those green antibodies. And those purple color antibodies that have coated the red blood cells, those are the antibodies that are present in the blood of the patient that you're testing it. So the test is positive in Coombs test if the Coombs antibodies or reagents or antisera form a bridge between the antibodies that have already coated the red blood cells, and now they cause a lattice formation and agglutination. Let's look at some of the applications of the Coombs test in here by this case scenario. A female neonate of an 18-year-old Afro-American mother is presented with severe jaundice immediately after birth. To find the cause of hemolysis, the blood of the infant is tested with direct Coombs reaction. The test will most likely be positive for which of the following causes of jaundice: thrombotic thrombocytopenic purpura, sickle cell disease, thalassemia, glucose 6-phosphate dehydrogenase deficiency, blood type incompatibility, or all of the above. Actually, the correct answer is blood type incompatibility. And the fact that the test had an Afro-American mother is not, as you're going to see shortly, much relevant to the correct answer if they point to sickle cell anemia or possibly to a lesser degree to thalassemia for you in this case scenario, but not to the correct answer. And the reason that I presented the question this way for you because I want you to remember an important fact. Two facts actually. One is that blood type incompatibility is where you're going to apply the Coombs reaction to. And secondly, as you're going to see shortly, this type of blood type incompatibility actually is less common in Afro-Americans. Now, among the given options, the only one that Coombs test will identify is ABO incompatibility. However, note that it is uncommon, and I want you to lock in this fact. It is uncommon for infants with ABO incompatibility to become significantly anemic, in particular at birth. Note that direct Coombs or direct antiglobulin testing, DAT, is helpful in finding if there is and immune etiology for jaundice or hemolytic anemia of the newborns. Non-immune causes of hemolysis such as thrombotic thrombocytopenic purpura, disseminated vascular coagulation, hemoglobinopathies such as sickle cell anemia, enzymatic deficiencies such as pyruvate kinase deficiency, and red blood cell membrane protein defects such as hereditary spherocytosis will all have negative direct Coombs result. Results of DAT tests are commonly positive in autoimmune hemolytic anemias, in drug-induced hemolysis, and in delayed or acute hemolytic transfusion reactions. So those are the most common places wherein the DAT turns to be positive. This brings me to summarize for you the diagnostic indications of the Coombs tests. Hemolytic disease of the newborn, HDN, autoimmune hemolytic disease, drug-induced hemolytic anemia, hemolytic transfusion reaction, and blood banking. Let's talk a little more in details about indirect Coombs test in blood cross matching. So as you can tell, this has an important implication for blood banking and blood transfusion. I'm going to be referring to the above diagram for you, and I'm looking at the indirect, essentially Coombs in this case, and this is the one that is of particular interest in blood transfusion, as you're going to see. We're going to do this test in the lab to make sure that the blood that we are about to transfuse to a particular patient will not cause a reaction in that patient. So the indirect test tests a sample of recipient's serum, not blood. Serum means that we have separated the cells in that blood for antibodies against the donor's red blood cells. So here you're going to see the packed cells, which is in red, of a donor, that you want to give these packed cells to a recipient. And in the recipient, you're looking for those purplish sort of immunoglobulins. Those are the ones that we like to screen for. So this is sometimes called blood cross-matching test. Note that this test is done on the serum for detection of IgG antibodies that can potentially bind to the recipient's red blood cells if the two are mixed together. The top two applications of indirect Coombs in clinical settings is for ABO and RH blood typing to make sure that the transfused blood of a donor matches with the recipient's blood. Note that the red blood cells of a donor with blood type A, they have A antigens on the red blood cells and anti-B immunoglobulins in the form of IgG in the serum of the same patient. In contrast, a donor with a blood type B has B antigens or B proteins on the red blood cells and anti-A immunoglobulins in the form of IgG in the serum of the patient. To give you an example, a well-matched blood recipient for a donor with type A blood must not have anti-A immunoglobulin in his or her blood. Thus, the recipient must not have type B blood in this particular example. An example for indirect Coombs testing is this. In a lab, a serum sample of the blood of a recipient with, let's say, type B blood who has anti-A immunoglobulin in his serum is mixed with the red blood cells of a donor with type A blood, means that there is A antigens on the red blood cells. The anti-A immunoglobulins coat the red blood cells, means that they attach to the red blood cells A antigens or A protein. Next, Coombs immunoglobulins against anti-A immunoglobulins are added to the mixture. Coombs reagent now will cross-link with the IgGs that are attached to the red blood cells. This causes lattice formation and agglutination. True or false? The Coombs test that detects non-agglutinating red blood cell antibodies is also known as indirect antiglobulin test. This is correct. Coombs test that detects non-agglutinating red blood cell antibodies is indirect antiglobulin test or IAT. The test that we perform on sensitized red blood cells is direct antiglobulin test or DAT. True false? Non-agglutinating antibodies that show positive Coombs results are most likely IgG molecules. This is true. IgM is a less frequent cause of positive Coombs tests. True or false? Antibodies that coat red blood cells do not spontaneously undergo agglutination due to the strong electronegative charges on the cell surface that repel the cells from each other. That is true, actually, because the cell surface proteins have negative charges. Note that when the Coombs reagent or immunoglobulins are introduced into the mixture, they will stick the red blood cells together via the two intervening immunoglobulins and force the combined ingredients to agglutinate and settle down at the bottom of the test tube. True or false? The direct Coombs test detects cell-bound antibodies. That's correct. This brings us to cover in detail this high-yield concept of RH incompatibility. This is important practically for all phases, all steps of your exam. It's going to surface in step 1, step 2, and the step 3, and in particular in the obstetrics for step 2 and step 3. What is the most important blood group system? This is the ABO system. RH system is the second most important one. However, as we're going to see shortly, in the obstetric settings, RH is by far a lot more important. So what is the RH blood group system, and what do RH negative and positive refer to? The RH system consists of 50 defined blood group antigens, among which the 5 antigens of D, capital C, small c, and capital E and small e are by far the most important ones. RH factor, RH positive, and RH negative practically refer to D antigen only, capital D antigen only. The D antigen is used to determine the risk of hemolytic disease of the newborn, the so-called erythroblastosis fetalis, which is a deadly condition. Blood with no RH antigen present on them is known as RH negative, whereas blood with RH antigen present is known as RH positive. What are the clinical importance of RH factor? The most important and clinically relevant scenarios are related to cases wherein the mother is RH negative, father is RH positive, and the fetus inherits the RH factor from the father and becomes RH positive. Another scenario involves a woman who is accidentally sensitized after receiving RH positive blood during transfusion or during an emergency transfusion. A mother who is Rh negative may develop antibodies to an Rh positive baby if a small amount of the baby's blood mixes with the mother's blood. If a small amount of the baby's blood mixes with the mother's blood, the mother's immune system responds by making antibodies against the Rh antigens of the baby's red blood cells in her blood. In other words, the mother becomes sensitized. Given that the mother's IgG antibodies can cross the placenta, they may attack the fetal Rh positive red blood cells in subsequent pregnancies. Or if there has been an earlier undetected placental bleeding, it may affect the very same fetus later during the very same pregnancy as well. Fetal red blood cell destruction causes hemolytic anemia, and if significant, may cause fetal death. 3 alleles are identified for D antigen. We denote them with capital D, small d, and capital D with superscript small u on it. And these are all located on chromosome number 1. As a result of these 3 alleles, we expect to have 6 genotypic variations: 2 capital Ds, 2 small d's, 2 capital DUs, a heterozygous capital D small d, a heterozygous capital D capital DU, and a heterozygous capital DU and small d. So these are 6 different genotypes. However, even though we have 6 different genotypes, we have only 2 phenotypes. These 2 are homozygous small d, which is known as Rh negative, and all others are known as Rh positive. I want you to know that capital D with U superscript is similar to D but is weaker. And I want you to know that homozygous DUs are by far the weakest. What are the chances that a fetus of an Rh negative mother and Rh positive father will be Rh positive? 25%, 50%, 75%, 100%, or the answer cannot be determined from the given information? Actually, the best answer should be option E. The reason is that the Rh positive father may have a genotype of homozygous capital D or heterozygous capital D small d, whereas the Rh negative mother must of necessity be homozygous for recessive D or small d. If the father is 2 capital Ds or homozygous for capital D, the chance is 100% that all children will become Rh positive. But if the dad is capital D small d or heterozygous for D, the chance is going to be 50%. In an Rh negative mother, which of the following conditions requires administration of RhoGAM to the mother? Ectopic pregnancy, stillbirth, abortion, chorionic villus sampling, all of the above or none of the above? Actually, the answer is all of the above. Just to know, all of the cited conditions and any procedures that may cause transplacental bleeding require administration of RhoGAM to the mother. An Rh negative man receives an Rh positive blood transfusion. Is this situation an indication for administration of RhoGAM or not? Actually, the answer is yes. I had this question on purpose in here so that you don't always automatically associate the concept of the RhoGAM with second pregnancies with a fetus which is Rh positive. What is the best management for an Rh negative pregnant woman who is the mother of a healthy 2-year-old Rh positive son who is not sensitized to Rh factor and has never received RhoGAM. Just to know, Rho D immunoglobulin is another name for RhoGAM. I want you to assume that in this particular case, both babies belong to the same Rh positive father. The best management is monthly measurement of the mother's Rh antibody titer. Then administration of RhoGAM at 28 weeks and then within 3 days after delivery. What are the chances that the first baby of a primiparous Rh negative mother with an Rh positive father will have neonatal hemolytic disease? Unless the woman has received incompatible blood products in the past, the chances are 0. Prior delivery of an Rh positive baby is required for sensitization of the mother. Do you expect the aforementioned pregnant woman to be a white or black patient? I already might have answered the question for you. This condition is more common among the Caucasians. 15% of the white population, they are Rh negative. Serum evaluation of an Rh negative mother at 27th week of gestation is indicative of very high titers of Rhd antibodies. What would be the best next step management? Would you like to administer RhoGAM to the mother, RhoGAM to the fetus, a spectrophotometric evaluation of amniotic fluid, chordocentesis, or none of the above? Actually, the best answer is a spectrophotometric evaluation of the amniotic fluid. Just to know, very high titers of maternal Rh antibodies are indicative of sensitization. RhoGAM, lock in this information and don't forget it, is only indicated for non-sensitized women. Evaluation of fetal well-being and extent of hemolysis is the primary concern in this particular case. Formerly, we used to use amniocentesis and chordocentesis because we didn't have these spectrophotometric sort of tools available to us. So we used to use them for obtaining samples for evaluation. These tests were intrusive. These days, ultrasonography, spectrophotometry are used, and they are safe and they are very convenient for the patients as well. Note that the best treatment for preterm infants is intrauterine transfusions and use of phenobarbital to induce fetal bilirubin conjugation. Of course, as you can tell, if we are in about 37th or 38th week of gestation, we may induce cesarean section. To give you a mnemonic to remember all of these and look at the clinical significance of Rh blood group system, I'm showing a mother who is Rh negative, means that she's homozygous for small letter D, and she's primigravida, means that this is her first pregnancy. Now her fetus is Rh positive. And as we can tell, the red blood cells of the fetus, they have D substance. Now she gives birth to her first child, and during parturition, some of the fetal blood with D substance on them, they mix with the mom's blood. Now she has anti-RHD immunoglobulin antibodies in her blood. At this point, we can say that she is primiparous or para 1 woman because she has brought a pregnancy to term. 2 years later, she gets pregnant again with another Rh positive baby. Now, we can call her pregnancy at this point Gravido 2 because this is her second pregnancy. Still, we cannot tell if it's going to get to term or not. At this point of time, you can call her Gravido 2 para 1 woman. Unfortunately, since she has anti-RHD IgG antibodies and they can pass the placenta, they can get into the fetal bloodstream and they can cause erythroblastosis fetalis. And the reason that the fetus says, ouch, you made me yellow, is the fact that most prominent finding is jaundice, and of course in the fetus and in the neonates that bilirubin can pass through the blood-brain barrier and can cause kernicterus and brain damage and possibly death of the fetus. Unfortunately, her second baby died as a result of kernicterus. Thereafter, docs wrote in her chart that she stayed as a Gravido 2 para 1 woman. She is now back to her routine, daily jazzercise classes. And that's the end of that story. So a Coombs positive newborn has hemolytic anemia. She has type A blood and her mother is type O. Which of the following options is the best explanation for this finding? The mothers often are not sensitized to A antigen. Maternal A antigen antibodies are IgM antibodies. Maternal A antigen antibodies are IgG. ABO incompatibility does not cause neonatal jaundice. The baby must be suffering from Crigler-Najjar syndrome. Of course, in this particular case scenario, option E sounds silly. The best answer is maternal A antigen antibodies or IgM. I want you to know that ABO incompatibility is by far the most common maternal fetal blood group incompatibility, and it's the most common cause of hemolytic disease of the newborn, not fetus, newborn. It happens when the mother is O type and the baby is A, B, or AB type. Infants are often A type because A type is more common. That's why we call it A, letter A. In contrast to Rh incompatibility that causes severe intrauterine or neonatal hemolytic anemia, the major clinical issue with ABO incompatibility is neonatal jaundice. It is postulated that ABO incompatibility does not cause hydrops fetalis because anti-A and anti-B antibodies are IgM, and as a result, they can pass through the placenta. Only a very small percentage of type O mothers may have clinically significant IgG anti-A or IgG anti-B antibodies that can cross the placenta. This is due to rare exposure to antigens that may be similar to the A or B antigens, such as the antigens that we get from E. coli, or antigens that we get as a result of blood transfusion. Note also that it's postulated that fetal red blood cell surface A and B antigens are not fully developed during gestation, and as such, there are a smaller number of antigenic sites on them. Therefore, even if the mother receives incompatible blood from a transfusion, it only causes a mild hemolytic condition in the non-O fetus. To summarize, in contrast to Rh disease, most cases of ABO hemolytic disease of the newborn occur in the firstborn babies, and the condition does not become more severe with further pregnancies. A very unique finding. True or false? Anti-Rh antibodies are given to sensitize the mothers. I already answered this. This is false. Anti-Rh antibodies are not given to sensitized mothers, but they are given to mothers at risk for becoming sensitized. True or false? A mother who has Rh positive baby and is not yet sensitized must be provided with anti-Rhd IgG antibodies at 28 weeks of pregnancy. This is false. Actually, I wanted you to pay attention to the language of this question. The antibodies to Rh factor are IgM antibodies. The IgG antibodies can pass through the placenta and may cause hydrops fetalis. Lock in this information. What is the best management for a mother with Rh positive pregnancy during the 34th week of gestation who is sensitized and is actively making IgG-Rh antibodies? In this case, the mother is already targeting her fetus with anti-Rh IgGs. The best course of action is to wait for lung maturity or to perform an emergency cesarean section if the lung is mature to avoid hydrops fetalis. Another option available to us is to do intrauterine blood transfusion for the fetus as well. True false? An Rh negative mother who has been given IgM antibodies, RhoGAM, for her past 2 Rh positive pregnancies does not need RhoGAM administration for her 3rd Rh positive pregnancy. This is false. RhoGAM, in a sense, acts like passive immunization. Remember, IgM does not survive a long time in the body. It acts as a passive immunization. And remember again, the immunoglobulin we use for RhoGAM is IgM. So IgM has a short half-life. The injected IgM antibodies will be cleared from the mother's blood over time, within 30 or 40 days.